I present to you another plenary panel. This one, healthcare supply chain during COVID-19. Take it away, Nick.
Wing, thank you very much. And thanks to my panelists, John, Ron, Sue, Dasu, Dan, and Laird. Thanks for joining. So let me just set the background of these initiatives we launched at the USC Marshall School Center for Global Supply Chain Management. It actually started with a simple thought. So it was just around March when within 1 week, I probably received over 10 to 12 calls. And these were not just the calls from just a small rural healthcare providers, but these were truly even in a large healthcare network, including Kaiser. And then the questions were around the disruption of supply chain through COVID pandemic and how it's impacting the healthcare supply chain. So if you think about in a contextual sense, 70% of the healthcare supply chain is managed by what we call the distributorship model in America, where 6 largest distributors controls over 70% of the total supply chain needs. And this is a very well-established network that works clockworks. You needed X things and it shows up on certain days and it replenishes and they manage end to end. So the questions that were coming, there were in many cases very basics to the supply chain world, but not very basics to the healthcare supply chain that was never exposed to the need to understand end-to-end supply chain. And so very first thought obviously led and Dan and others, we have a consortium of directors for supply chain across the universities to say, how can we leverage the academia, the university supply chain institutions, industry, and then practitioners, and how do we come together as a sort of a collaborative model? And that thought led to the conceptualizations. 30 days into it, we have a full-blown initiatives that I'm so proud that my colleagues, many of them here on the call, as well as many others in the background, including the office staff at the center, came together really to create this comprehensive strategy on healthcare supply chain during the COVID pandemic. So with that, we have 3 streams. Stream 1 focuses on the model and taking the data, the disease data, and then translating that into the supply chain forecasting needs. Dasu and Laird will touch on that. And we actually wanted to create some sort of a supplier database so that this community that is first time getting exposed to buying the needs directly have some credible sources to work within. And we'll touch on that stream 2. And then stream 3 really was the basic execution of last mile delivery. In many cases, even the first mile delivery, because a lot of these frontline healthcare providers were first time exposed to these practices. So we wanted to make sure these 3 streams independently, but interdependently work together to answer this end-to-end questions. So why don't I start with our stream 1 and give us a quick background, and we'll pass on to the stream 2 and then to the 3, and then we'll get into the Q&A.
Hey, thanks, Nick. So as Nick pointed out, the objective of stream 1 was really to help our users develop procurement plans. And the vision is to provide the public a set of tools that are also sourced from the public. And in terms of what we want to do in the stream, it is convenient to think of our tool set in sort of 3 dimensions or axes. The first dimension is the data flow. The second is the time horizon for the forecast. And the third is geography and facilities. So let me begin with the data dimension. We want to provide users the capability to go all the way from data that's primitive to epidemiology models to detailed procurement plans. So a user can start wherever they want to, ideally. So for example, someone might say, here are a set of policy decisions that we think are going to come down. Here is some mobility data. Here are some behavioral data. And here is data on how the disease is spreading. What are the implications in terms of PPEs and a procurement plan? So the first translation would be from primitives to epidemiology to predictions of disease progression and PPE requirements. The next progression would be from requirements to perhaps scenario-based planning and to detailed procurement plans. So that's the data dimension. So you start in one place and end somewhere else, but we want to give users the option about where they want to enter and where they want to leave. The second dimension, that's time, and here there are a plethora of forecasting models out there. Some are very short-term horizon, essentially data fitting models that maybe project out 5 to 6 weeks. And then there are more sophisticated models that might look out into several months, maybe 5, 6 months, and generate scenarios. So that's the time dimension. And the third dimension is geography or facilities. So potentially users might look at what their needs are at a single facility, or there may be groups of facilities, a network of, say, providers. An alternative way of aggregation is geography. So you could think about what are the needs in a census tract, what are the needs in different states or regions. So when this is done, our hope is that a user can look at any level of aggregation, any time frame, start at any point, but end up with a procurement plan. So that's the high level version of Stream 1. And now Laird is going to talk a little bit about some of the details of the models.
So one of the areas we looked at, there are various models out there. We'll talk about a couple of them. One is called a CHIME model. It's a publicly available model. And it did a SIR, or a susceptibility infection and recovery rate. And we found out early in coronavirus, there's a latency period that we all know about now. And so now we are working to modify that to what's called an SEIR model, which is susceptibility and
I'm going to cheat here and look. It's the exposed.
The exposure part, as well as the infection and recovery. And we want to look at those models and try to tune them to improve the fidelity. But one of the challenges that we found is that if we just model a city or we model a region and people are staying in place, the model can work pretty well. But as we all know, people travel. And early on, we were starting to shut down the traveling part because it was making the infection rates and the propagation much more serious. And so we're looking not just at this particular pandemic, but pandemics in general, should this occur again, and saying, how can we look at it so that we either restrict travel and some of the social distancing challenges that states are dealing with, or in some cases, when we start to relax them, how can we also model that? Because our healthcare systems have to deal at that point with the various infections and how they're going to get the supplies to treat people. And so we've looked at the CHIME model. We're working with the CHIME model, and we're working with what's called a BEAR-MOD model, BEAR, BEAR-MOD model as well. And that's a travel-based SEIR model. And we're working with Esri, looking at some GIS data, some Geographical Information System data, working with some data from Google and Apple and other source. And we're trying to say, how do we take a basic model, make it available to regional health centers, for example, but also smaller local health facilities that don't have the resources for the modeling and capability, and how do we tier our approach to them? And how do we add some value so over time they can continue, as Dasu said, to take a look, what are our resources, what do we expect the infection rates to be? We're looking, for example, at the 3,100 plus counties in the United States, so we can model at a better fidelity than has traditionally been done. So we're looking at some of these tools, and one of the reasons we're doing that is not just to anticipate what the needs are, but to work with our colleagues in Stream 2, so that as they source the particular new capabilities where old suppliers have stocked out and we're bringing new suppliers online, they've got some input into the kinds of demand they have to deal with. And then in Stream 3, which we'll talk about in a few minutes, about the last mile delivery, how do we connect, as Nick said, this integrated process we're on the front end of it, but we are highly dependent and working well with our other streams to bring this systematic approach to bear. I think I've lost your sound.
Yep. Thank you, Laird and Dasu. Stream 2.
Hello. So do you want me to introduce myself or?
Yes, please, Sue.
Okay.
Appreciate it.
Okay, thank you. First of all, thanks to Nick and our wonderful team here. It's been nice to work with all of you and getting to know you and working on this very important problem of our healthcare supply chain. And I am Sue Sundar. I'm a faculty member at the University of Utah Business School and also the director of the supply chain program here. Thank you for being here. And as Sriram, Dasu talked about stream 1, and so in stream 2, we basically, took what they worked on, and the aim of stream 2 was to basically create an information portal for buyers where they can source the PPE supply that they need. Now, as Nick pointed out in his introduction today, that there was a shortage, or there's probably still a shortage going on with COVID. And it was pretty profound when we started with COVID back in March, and there was a disruption in our healthcare supply chain because of the COVID. And like he mentioned, 70% of our healthcare supply chain is managed by distributors. And how do we, if we as a hospital or as a provider, we have a shortage of these really important PPE requirements, how do we deal with that? And so that was the reason we came up with the idea for stream 2, is that we wanted to create an information page where buyers can source the PPE supply that they need. So we had a team of people in stream 2, and basically we wanted to create or help people find what they wanted by using key search words in this portal. So the search words would be things like, the list of PPEs that you wanted. So just to give you a sense of our personal protective equipment for healthcare staff, handling corona could be anywhere from an eye protection, like a face visor or goggles that you would need, or something like a face mask or special kinds of face masks, different levels, different qualities, different standards, and then gowns and gloves and so on. And so all of that, if we have a shortage, how do we deal with something like that? And so in our USC website, for stream, we have stream 1, stream 2, and stream 3 spelled out there, so we can help users reach whatever they need to, or help them reach their goals. And so here, for example, you can search on information sources, or you can search on marketplaces. You can look for direct suppliers. You can also have general information about the sources itself. You can also look for certain distributors. If you're looking for some, you could look for that in that manner, or you could look for certain factories and stuff like that, or specific PPE equipment as well. And since we started this, since this has been launched, we've had thousands of hits for information on our website. And we have taken basically, we're hoping to fill some gap that there is right now and help institutions and bodies there to fill this need. So I think that's about it from stream 2.
So thank you. And just to give you some context to that, I mean, even USC, obviously we have a big healthcare facility we provide to the Los Angeles County as well as the Keck Medical School. They were able to procure gloves, masks, and some of the other PPE SKUs through this process. So certainly is actually really useful, and that's only in the intended benefits that we started out with. So thank you, Sue. So Ron and Dan, stream 3, let's talk about, because this was certainly the gap that we saw, that this industry vertical had a massive knowledge gap. Let's touch on that in stream 3.
Thanks, Nick. And Ron, if it's okay with you, I'll start things off and then let you interject as well here. So thanks, Ron. So Ron and I co-chaired Stream 3, which if you look at holistically what we were trying to accomplish across the 3 streams, we were really trying to take advantage of a university industry collaboration and look at, as Sriram and Laird talked about, the forecasting piece. Sue talked about this repository of connecting suppliers, manufacturers with healthcare providers, and then how do we get the goods from A to B in that first mile, middle transitory period, and then in the last mile delivery. As we built out the Stream 3, what was interesting was initially just putting out fires. So if you look at one of the ways that the entire consortium sliced and diced this logistically was you've got local players, think about your clinics, hospitals, local providers next door in your neighborhoods. Then you've got county health providers in most states or parishes in some other states. Then you roll into state level, regional level, national level, and you've got all these different county health officials, providers, manufacturers trying to work together. So in the early phases of the initiative in the consortium, I was linked up even in Iowa with some of the last mile logistics of literally delivering things to hospitals and things of this nature. And every state was a little different. As Sue mentioned, many had shortages. Others had actual surpluses. Some states had overstocked from the swine flu pandemic and had extra inventory. So some of it was about inventory balancing and connecting manufacturers. I still remember vividly in the early days being on the phone 1 minute with a gown manufacturer that used to make tarps and tents, and the next minute with county health officials, and the next minute with someone delivering them from A to B. So we were literally at that level of tactical operation in some of the consortium early on. As we got a little bit broader and looked at this more holistically for the country and moving supplies, we had to look at custom and import clearance. And there was, of course, a lot of counterfeiting going on early on that we heard about, and that's still going on today. And how do we address some of the import-export control processes? And if you're a healthcare provider or a supplier, what sort of regulations, restrictions, protocols do we have to comply with on that customs import-export side? And then as you get into the last mile, who are the group purchasing organizations? Who are the distributors of the healthcare supplies that can get them from that distribution center warehouse location regionally to the end users where they need them out in the field? And we've of course seen the media coverage of what happened, especially early in the pandemic with shortages of PPE, and how do we make sure that we can move that process along? And there was a lot of industry university collaboration going on, particularly in Stream 3 as it related to those topics that I covered. Ron, anything you want to add that I haven't touched on in terms of the kind of overview of Stream 3?
Yeah, just a couple of things. So I'm Ron Volpe. I'm the Senior Vice President of International Markets for Persequor. We're a track and trace software company based in Denmark. And look, I applaud the group for allowing me to be a part of it. I come from a bit of a different background. So prior to being with Persequor, it's all food supply chain. So I was with Coles supermarkets in Australia, running supply chains, and before the Kraft Foods Global running supply chain. So I came to this group with a bit of a different background, a different perspective, and hopefully I was able to bring, and I think the way it worked out, and I applaud Nick and the team here, it was able to bring some learnings from food and beverage that we were able to leverage within healthcare. And to Dan's point, the trajectory of the work we did was interesting because I think about it as starting out as a bit of whack-a-mole in terms of matching requirements with people that had solutions. And then I think we moved into building sustainable relationships between parties across the supply chain in terms of shippers and receivers. And look, I come from a design thinking background, so I worked with IDEO for a number of years. So I think the third stage of this that I'm hopeful that we see is companies starting to build supply chain into the design of the product like they do color and function and shape. So the notion of how do we take it to the next level in the future, both here in healthcare and elsewhere, by building supply chain design. And the last comment I'd make is in terms of the way we looked at it, and if you go to our website, you'll see it, we built it across a number of axes. One was I need specifications. So how do we give organizations direction in terms of that need specifications for building a product? I can pivot. So I'm not building PPEs today, but I can build PPEs in the future. How do I do that? How do I get the product from here to there? What's that last mile delivery look like? And then lastly, the last axis was QA and QC around manufacturing. So that's how we approached it. I think the team did an amazing job getting from where we were in March to now. But that was what Stream 3 worked on.
Thank you, Dan. Thank you, Ron. And just my audience, please send your questions and I will try to incorporate along the way. So let's start out with, just before we begin our panel here, the President Macron just announced 10 to 20 minutes ago, right off the press, 9 major cities across France, starting Saturday, will have a curfew from 9 p.m. to 6 a.m. So Dasu and Laird, you guys spoke about the exposure and the contact tracing. This is a huge challenge. We see this back home also. About 17 states have seen the uptick in this COVID through the exposure. So how do we see this issue of COVID in terms of the being able to contact trace and then its continued influence down the supply chain on the demand side? That's who you're on mute.
Oh, I'm sorry, okay. Laird, do you want to take this or you?
But there's a lot of interesting pieces there, Nick. Australia has had these curfews for a little while now, for example, and they've done a pretty good job of dampening it down. But here in the United States, it's challenging because we have a lot of economic effects like places do around the world. And the question is, how do we balance being careful about COVID with obviously not being too careful and making sure we can still have jobs and do those kinds of things? And politics aside, from the modeling side, we know that people who join social gatherings or travel increase the propagation of the pandemic. And so on our team, we're trying to look at how do we incorporate those pieces into the model. So again, we started with some basic, very good open source models, and we're adding those kinds of interactions so that, for example, in the French case, they're adding curfews to a city. We'd like to be able to show in the models as we continue to develop them what happens when you add curfews and restrict some movement in the models. Again, using the GIS capabilities we're building into some of our forecast models. And how do we help provide not decisions, but simply guidance on how these effects can increase or be decreased based on public policy as our political leaders need to do. An example I use when I teach is, it's like the old movie Gone with the Wind, where you've got the Wizard of Oz, and in the background there's this noise from Oz, and nobody knows what Oz is, but he's the great Oz. And eventually Dorothy and the crew show up, and they find out it's a guy, behind a little curtain, and he's pulling some levers. And our job and our viewpoint in the Stream 1 is to say, let's help figure out what those levers are so that we can simply provide good forecasts to the healthcare providers. And should the decision makers in our states and our regions want that information, they can look at in the future where we build in the what if scenarios. What happens if we're able to release some restrictions or if we need to add restrictions? So we're looking at those complexities that are just inherently in this pandemic by nature, but have not yet been incorporated in our forecasting capabilities. Dasu, did you want to add anything to that?
No, I think Laird did a really good job of laying out the groundwork. The point that we want to make here is, again, like Stream 1, Stream 2, and Stream 3, is we really want to be almost like a crowdsourced platform. It's not that we want to build our own tools and models. If there are gaps in the space, we will incorporate them. But eventually our objective here is to offer a menu of options. And as we learn more about COVID, we have, a large number of universities and research institutions that are developing various types of models, both in industry and academia, both in terms of different types of data sets and different types of models. And our, goal really is to make these tools available at our site. And as Laird was pointing out, users can vary from, single facilities that want to make simple decisions, or, sometimes the users could also be outside healthcare. It could be, for example, people in other retail sectors, or it could even be, police and security forces that might want to understand as these diseases progress, or, what are the implications. So, we are still at a nascent stage relative to streams 2 and stream 3. And the vision is really for to answer the kind of questions that Nick was raising, but by using publicly available tools and techniques.
Thank
Hey,
you,
Nick.
Das. Yeah, go ahead, Ron.
One more build on that is, and related to your comment about Macron and related to some of what Dasu and Laird talked about, I think we saw some of that challenge come into our space and execution as well, in the sense that we ended up, and again, politics aside, we ended up managing this sort of at 50 different buckets. Every state was approaching this a bit differently. And I think that made the challenge of, in the absence of kind of a federal national direction on certain activities, we ended up finding that the rules changed and the rules were different state to state. And I think that made the complexity of the issue a little more challenging to deal with, I think.
Absolutely, Ron. And the federalist model that we live in, I mean, that sort of a command and control does not exist in almost most cases. And that certainly poses a challenge. But that gives a really good segue into, John, your world as City of Hope. How did you guys feel about this disruption? And I'm sure we talk about end-to-end disruption, but in your case, it is the last 1 feet. A physician who wants to see the patient raises his or her hand, and there is no PPE equipment available for her to be able to provide that service. How did you guys initially felt about this, and in the context of what we're doing, if you can just give us a background?
Yeah, thank you for the question, and thanks for the opportunity to be here. For those that don't know me, I am John Reuter. I work for a specialty cancer care hospital here in Duarte, California, about 20 miles from Los Angeles, and this has been a significant challenge for our organization. It hit us as hard as any organization, and the challenges were not just with PPE. They were equipment like ventilators and ECMO machines and lab testing supplies. So it was a very significant impact, and I would say, and still to this day, we have, daily huddles and, work groups and teams that are being pulled together to manage what is still, largely unpredictable. It's hard to know how many COVID patients are going to present. There's not great collaboration, and almost little collaboration, quite honestly, with other local healthcare institutions. And, it's every healthcare organization for itself to treat their patients and ensure that they've got the necessary supplies and equipment. So, what I will say to, maybe support some of the earlier discussion with regards to, technology solutions and data modeling and business continuity plans and, demand forecasting and, having I'll call it a scientific approach to managing this. I think those are helpful and they are necessary, but I think that there are I know from experience that you're dealing with humans, and there's the human element that comes into this that make it challenging to rely exclusively on your systems. And what I mean by that are, when you think you have a warehouse full of inventory, you've ordered from a supplier that you haven't been able to do the appropriate due diligence, and so you have quality issues. So you don't have the inventory that you thought. You've got people hoarding inventory. You've got people that are going to come into your warehouses and steal your inventory. These are real life examples of things that are special cause variation and unpredictable forces that are going to require a very solid team that can think creatively on the fly and that can work collaboratively to figure out what we can do in a real life situation to try and manage through this on a day-to-day basis when you're dealing with critical patient safety and patient care issues. So my comment, and one of my many key learnings in this is that again, planning and data modeling and robust processes and systems are necessary, but they don't always work perfectly. And what I call a case, a manufacturer may know it as a box, and so we're not always speaking the same language. And so there's a lot of things that happen that introduce variation into the system that require a good mix of people, process, and technology that work in a fluid way to manage a very, very dynamic situation.
So thank you, John. And so let's go back to the thought. You brought up a point about the competition and the inventory crisis that not only the COVID created with the disruption, but human factor also played in, right? For the same source, the local, county, state, and even in many cases, the federal government were all fighting and bidding up for the scarce commodity and the resources. Have we passed through that cycle? And do you think if the second wave were to come in, which we're seeing inclination in Europe, has that behavior, have we learned from it? And do you see the different outcome in a second wave, should that become real?
I think we've gotten better. And again, I think we've been able to rely on local and state authorities to help bridge gaps when we've had a challenge. But when you think about a pandemic, there's greater impacts other than just PPE and supplies that I believe need to be considered. And right now it's every institution for themselves to determine how they're going to manage the patients that present. And other countries and other parts of the world have had more coordinated effort on determining which hospitals COVID patients are going to be treated at, and have better coordination of ensuring that designated hospitals receive designated amounts of supplies and priority for that inventory, and ensuring that those designated hospitals are also given priority for the equipment and the resources and the staffing in order to ensure that the supply and the demand are able to be managed. And what I'm seeing is that we're still not there yet. I am fortunate. I've got a great team, and we are sitting on probably 4 to 5 months worth of inventory of all key PPE and supplies. We've got a list of 40 or 45 items that are critical for us. I can tell you that my neighboring institutions, down the road are not in the same position that we are. And I can also tell you that they have less COVID patients in their hospital than we do as well. So we've got an imbalance of coordination, and I think that we need to be thinking about this more holistically at the providers and where we're going to see and manage the patients, so that we can be in total coordination of our efforts. And that's the level of planning that I think that we need to get to, and ensure that we can do the best job as a coordinated system on how to manage not only the supply chain, but also the human resources and other resources other than supplies that are needed to get through this pandemic.
Dasu?
Yeah, thank you for clarifying this, John. And I think one of the reasons that this consortium that we are here on is interesting is because this is really the space that we thought was missing, in the sense of how do we create coordination. And when COVID came about, we thought that several things were different for healthcare providers. One is that the kind of skill sets that you are normally used to are not really fully applicable in this context. For example, you don't really need to worry about this level of, say, data modeling, for example, or to deal with providers that you never actually dealt with previously, or even coordinate across healthcare facilities. And I think this consortium was kind of born out of this feeling that there is a need for creating an entity that at least provides a platform for some kind of coordination. And I was wondering whether if you think there is a space for a public-private partnership or university, industry and healthcare provider partnership that can move this to the next level to address the kind of concerns that you're talking about.
I do. I think it's, quite frankly, I think it's necessary. And, I think that there needs to be formal and also informal ways in which our healthcare industry can collaborate. We've got, 6,000 hospitals across the country, and, they all have different, motivations and initiatives. And it's always surprising to me. I've been in this industry for, over 15 years now, at the lack of collaboration that exists, and quite frankly, the competition and the perverse incentives that exist in the industry that really undermine collaboration. And so I think that there absolutely needs to be public-private partnerships and also leveraging the expertise and the innovation of academia to help us come up with a better model. This has been clunky at best. We're not through it. I've heard folks in our senior leadership ranks describe us as being in the third inning. So we've got a long way to go before we do get through this. And I can say one thing for sure. There's not a hospital CEO out there that doesn't understand in today's day and age the importance of having robust supply chains. And so, the time is now to, there's no burning platform, or we shouldn't let a good crisis go to waste with the time that we're in now, and really dedicate the effort and the focus to making some significant improvements that can take advantage of the learning opportunities that we've discussed.
Thank you, John.
Thank you very much, John.
Yeah, that's a great point. So Sue, let's talk about what John shared. And I know we talked about some of the contact tracing. And is there any opportunity for supplier portal of knowledge that we created to be enhanced in a way where we can provide sort of an improved value proposition for sourcing capabilities for the hospitals and various stakeholders? You're on mute.
Sorry about that. So yes, Nick, absolutely. So as John mentioned, I think we have to learn from this crisis. So so I think this portal coming, all of us coming together, like Sriram mentioned, has been a need. Actually, there was a need for developing the Stream 1, Stream 2, and Stream 3, and making sure that, just one sec. My computer is saying that it's I just need to plug it in. Okay, great. So the thing is here, yes, we do need, I think we learned, as in Stream 2, we learned, what kind of suppliers are needed and how we can continue to look for suppliers out there. So our eyes are always there for looking for, newer suppliers if we want to add them to the list, and sort of make sure that we help with this whole procurement in the healthcare supply chain, making sure that, there are institutions like John mentioned that are hoarding, and then there are institutions that have a shortage. How can we connect these two players together? You know, people who have more than what they need, and then people who have less than what they need of certain things, and then connecting them together. And that's what I think this USC portal has done for all these suppliers and for the people that need them.
So John, to that point, you mentioned 6,000 hospitals. How does this initiatives that we've worked since March so hard on, that we can provide similar access? Obviously, these initiatives, we've been so much in the trenches trying to build this infrastructure, and we have not had a chance to do the outward facing reach to the stakeholders, the hospitals that you say. What would be the easiest way for you think stream 1, 2, and 3 to actually present this opportunity for them to use this as a resource?
Well, I think there's a couple of things. I think there needs to be, top down as well as bottom up work. I mean, this is an effort that I think I've seen in a lot of different areas where, folks are in organizations trying to, trying to harvest the learnings and put forth some, these learnings into practice. But I think that it would be helpful if we can find an institution that we can partner with, a large reputable institution that we can pilot these programs, and that we can generate a business case and data and information to determine how these models can work and/or potentially refine and optimize the models. And and I have to believe, based on what I'm hearing, that there's there would be interest in this area, or potentially other areas of the country that we could partner with, and so I think that would be a first step. And I think concurrently we've got to lobby our public and elected officials to begin addressing some of the bigger problems that exist with our healthcare system, that prevent collaboration, that prevent a level of coordination for how we handle these types of events, and how we can really work together as 6,000 hospitals to, because this isn't the last pandemic that we're going to see, but it's most certainly something that we need to learn from and figure out how we can begin to be able to operate as a more organized system, rather than every facility for itself.
And John, I like your idea of, your comment about being in the third inning, I think resonates for me. So I think one of the things we also have to do, I think, is paint the picture of what good looks like for the future. So if you think, I think of it in a couple axes. How do we accelerate digitization? I think COVID has been the biggest accelerator of that I've seen in some time in supply chain. And then also, is there regulation we should be looking at as well? So the FDA has just made changes for food, for instance, and some proposed changes as a result of COVID. So I think we've got to we can't always do it the way we're doing it today. And I think we've got to figure out and help supply chains understand what good looks like from a digitization perspective in the future, because it can't all be manual.
So the question to that point, that this will not be the last pandemic that we'll deal with it. Hopefully not the size and scope of COVID, I suppose. So Dan, the question came from the audience is about what lessons have you learned and what can we implement? And after Dan, obviously it's open to my other panelists as well.
Yeah, so I think one of the things we're trying to do is through summits like this one, other conferences, publications, we're trying to have some outreach to show what the initiative's accomplished. If you noticed in the chat window, I put the website URL, which then will take you to essentially the pieces that were built out by the stream 1, 2, and 3 that we've referred to. So you can take a look at that website, but sharing this information and really discussing it and cascading it through those local, regional, state, federal players. It's unfortunate that there were so many disconnects, but I've also talked to people to be a little bit more positive about some of the vibe of the conversation here. Some of the distributors in particular, when we looked at logistics, they said, we were ready for this. We have not skipped a beat. Now, did all of our partners fully understand what they wanted to do? Maybe not, but in many cases, the chain did not completely break down. It was more about anticipation. And a lot of experts, epidemiologists said a pandemic like this would happen. I personally didn't see it happening in my lifetime, and here we are. So there are things like this where they catch us blindly, maybe a storm coming through or something like that, like a hurricane or natural disaster. There's some commonalities and links between humanitarian aid, global relief, disasters, and pandemics like this in general. And there's a lot of supply chain work happening in that humanitarian relief side as well. So Nick, I'll hand it back to you, and then any other panelists that want to talk about that topic.
Any thoughts from my other panelists on what lessons have we learned and what can we learn from this for the future? Not just a pandemic, for me, any natural disasters. When we happen to be in California, hot zone of earthquake, I mean, disruptions. I don't think this is the last disruptions that we're going to be facing. Any thoughts, the lessons we learned from here?
Nick, one of the things that we realize in our field and as professors and academics studying supply chains and supply chain design is that if you look at our hospital and healthcare systems, for example, they're fairly stable systems. We do occasionally have a natural disaster or something, but we plan for those with some anticipatory inventory and things like that. But for the most part, it's a stable system. And so what happens in these stable systems is we bid it down to holding strict quality requirements. But with those quality requirements, it's a cost-based system, and we minimize cost because it's an efficient and predictable system. And then this unpredictable demand comes in with a pandemic that we're not used to. And all of a sudden, we're in the kind of ballpark that the Nobel-winning World Food Program has to deal with every day. They not only have uncertainty in demand, they have uncertainty in supply, which is exactly the boat we're in. And our supply chains were not designed to accommodate that. And so we're seeing some firms making a transition to becoming suppliers and doing some PPE and things like that. We're looking at new changes in the network. At some point, it'll stabilize back down into a balance. But there are lessons we can learn from other areas that deal with uncertainty in demand and supply and look at how do we apply these. At some point, I think John talked about we want to talk to our political representatives. At some point, we want the regional and national planning should another pandemic occur, because there are costs that a lot of these regional centers can't prepare for in the long run. And the example is, if I'm a firm and I think something uncertain is going to happen, so I increase the flexibility of my supply chain at a little bit higher cost, and the pandemic or something never happens, I lose competitively to the cost-based firm. It's only when it hits that the cost-based firm gets into trouble and I might win. But it's a challenge figuring out those probabilities. And so part of the role we can have from a government leadership standpoint is perhaps having like the national stockpiles and some of the pandemic planning capabilities to do the kinds of larger scale coordination that John and the rest of us have been talking about, to say, let's have this coordination. And it's one of the, I don't want to say dreams, but the hopes of this group that in the future we can figure out how to make better integrated models so that we can at least share those with the regional health centers and perhaps with our politicians to say, here are some tools that we and other academics, we don't really care who develops them. How do we bring tool sets together to help our nation and perhaps some other nations in the future to learn how to adapt to the higher demand uncertainty and supply uncertainty that this pandemic has exposed in this particular industry, along with some others.
Thanks. So let's stay on the same line. There's another question about the modeling, and Dasu, you and Laird, you guys can take a first crack at it. Is what are the factors we consider when we're modeling something, and how do we ensure that legal groundings and some of the, there's a lot of conversation about the AI and modeling capabilities that might discriminate certain things or not really address things in a certain ways. How do we factor those variables into the modeling?
Dasu, you want to start?
There are so many factors that you have to consider when you develop these kind of models. And so, in modeling, there's always a bit of an art, right? In the sense that, are they broad scenarios that you're interested in, or are you interested in micro details, right? And so we have to kind of work your way through in terms of what matters, what doesn't matter, not so much from a detailed modeling perspective, but in terms of what are the implications on the decision that you're going to make. And as John pointed out, when you run into these kind of crises, models bring you to a certain ballpark. They don't they don't take you to this precise spot. So I think one of the challenges in modeling is what's the level of detail you want to incorporate, and really it has to do with what's the decision that you're going to make. And that's one aspect of modeling. And the second thing that I want to kind of reiterate is we don't consider ourselves as the experts in epidemiological modeling. I'm not, for sure. What we're trying to build here is a portal that serves the purpose of aggregating collective wisdom. And so those are my two comments on that question.
And
Laird?
as you start with these models, we had these kind of localized models for the SIR and SEIR models, and there's some good models out there to do that. But we found out, for example, we'll just use USC's in Los Angeles. And if you compare the population of Metro Los Angeles, it's larger than certain states with a higher population density. And so we can't compare the way the disease spreads in Iowa with the way it spreads in a large city like New York City or Los Angeles. And so we're trying to add some capabilities to that model as to how people interact. And so we're using some anonymized data at this point, again, from Google and Apple, where people move around a little bit. We're trying to understand the movement patterns and the exposure patterns and the density patterns. And we're not looking to, get anybody's proprietary information or track people or things like that. But with my university, for example, we're part of a 3-university system. We can opt in to a tool that allows us to see if we're exposed around other people who have also opted in, and they can let us know. So if people want to opt in, that's one thing. We're not dealing with those kinds of tools at this point. We're certainly not looking at AI. There may come a day when we can do that, but if you spend enough time understanding modeling, you can come up with a lot of really cool, sophisticated models, but if they don't have the fidelity of the underlying problem, they're just advanced video games that convince you to do some policy decisions that are not founded in reality. So we're trying to take this modular stepping stone approach, and as Dasu said, take some tools from the open source and leverage some other tools from other places, fill in some gaps, and incrementally try to build how do we shed insight where, for example, I'm in Huntsville, Alabama, and it's the birthplace of NASA, but we don't have a huge healthcare system here. Our needs are going to be different than they are in Los Angeles. And so how do we help those particular regions look at how the propagation of the pandemic may happen, and how can they tune their models to their regions, even perhaps down to counties in some cases because of density. So we're not at the AI stage yet. There may be some people experimenting with that, but we're looking at the fundamental building blocks and filling the gaps with tool sets that we can bring together and simply try to help better inform our regional and local medical centers, as well as hopefully some political entities on the way.
So Laird and Dasu, so if I may just add to that, I think the modeling, obviously, you always think about the objective function. What is it that we're trying to impact on, right? In some cases, we're trying to minimize something. In some cases, we're trying to maximize something. And then you have a set of variables. I think when we launched this initiative, to answer the question that came from the audience, is that our goal was not to find the perfect solution, to look for the silver bullet here. I think our goal was that we saw a huge gap, a gap that was systemic, a gap that was obvious, and gap that really created our inability to take care of the frontline healthcare facing population and put them in a danger. So we started with the objective function of how do we build that bridge to overcome those gaps that were structurally identified during the COVID crisis. So when you are working with the modeling, sometimes you have to start with that at the system level objective function, and then you start to focus on the subsystems and then the complexity that starts to build onto that. So if you are planning to think about modeling in any scenario, I would say look at it in aggregate, what's the objective function, and then get into the granular detail, but don't lose sight of trying to come up with the perfect solution and missing the golden nuggets on the floor that you can pick it up pretty quickly. And then that's the objective of this panel. And what we have done at the USC was to really make an impact, make it quick, and help our constituents and our society as quickly as we can. To that point, let me sort of bring sort of a wrapping up by making an introduction, and then what I'm going to do is just provide each of your background quickly, as you guys been really part of this thing. So I'll start with Dasu, who's a colleague and dear friend. We both actually happen to be in what we call at the Marshall Business School in the data science and operations. So Dasu, thank you for joining this call. Laird, who is an associate professor of management science and supply chain management, University of Alabama, Huntsville. Laird, thank you. Your continuous work on this panel as well as speaking today. Ron Volpe, as he mentioned, Senior Vice President, International Market, Persequor. Thank you, Ron, appreciate it. Sundar, Associate Professor and Lecturer, Director of Operations and Supply Chain Program at the University of Utah. So thank you for all the work on the stream too, and appreciate it. John Reuter, Vice President, Supply Chain Management, Facilities and Construction, City of Hope. John, thank you for your insight from an amazing stakeholder who's been going and dealing with this crisis that we are facing. And Dan, who is an Associate Professor and ESP Fellow for Supply Chain and Logistics Management, at the University of Northern Iowa. Dan, thanks for driving, and you have done a lot of work across the stream as well. So thank you, all of you. So just last minute, let's go through sort of a fire round, 1 minute. Is there a second wave, and if so, are we ready for it? We'll start with you, Sue.
I would like to think in the world of, if I could change things, I would like to say no, but it looks like we are getting to a second wave. So, we see our numbers rising. Here in Utah itself, we saw a huge rise this last week. And it is scary, something that wouldn't go away if we close our eyes. And what is it that we can do, both as individuals, to control this, and also as supply chain people here? What can we do to sort of control this? And also, by control, I mean trying to slow down the growth if we can. And on the other side, if we have to deal with this, then how do we deal with this effectively as supply chain professionals, and as coming from industry and academia and other professionals? How do we help our economy and our world to be able to meet that gap, and to be able to see that, if there is a gap, and where exactly the gap is. And so we can learn from this first wave, whatever we've learned from our first wave, apply that if a second wave happens, and make that a smaller wave if we can somehow make it much smaller than it would be otherwise if we hadn't, if we hadn't had the experience. And also being able to learn from our lessons. I think that's important, because if we don't learn from our lessons, then this is a wasted effort. So we do have to remember what our lessons are, and make sure we are even prepared better than what we were in March.
Thank you. Sue, Laird?
The short answer is yes and no, Nick. Yes, we'll have a second wave. Hopefully it's going to be dampened. It happens in all these kinds of pandemics over the years. We didn't anticipate it. So hopefully in not only our consortium, but in other areas around the country and the world, we're going to anticipate that we have to both have some better anticipatory inventory and also some more responsive supply chains in order to try to balance the challenges of unpredicted demand with uncertain supply, much like the World Health Organization does. I think we can get a better handle on it. But, the laws of nature and disease propagation won't change. And we're a much more global world now. We have a lot more travel, and the disease was spreading before we knew it in countries we thought we were safe, and all of a sudden it's hit a bunch of cities. And so the better we can be prepared, and the better folks like us and others can model and anticipate it, the better we can help society to have a more improved response.
Thank you, Laird. Dasu, we're gonna move quick.
Yeah, quick. I think it'll be, as Laird said, I suspect it's going to happen, but I'm an optimist. I think we've learned, and we're going to do much better.
Thank you, Dasu. Dan.
Second, what Dasu said, I believe that we will see a second wave, kind of like the flu season we're rolling into, but I think we've learned from it and we're better prepared for it now. It's just a matter of how bad it'll be.
Thank you. John, your perspective.
Yeah, I think what we're going to see is continued ebbs and flows in areas that are going through peaks and valleys, but will we see another major spike? I certainly hope not. I hope the learnings that we've learned with social distancing and masking and the precautions won't create another major spike like we saw in April, May, and early stages. So I'm optimistic that we're in for and that this is going to be able to be managed going forward without another significant spike.
Well, thank you, John. And Ron, I'm not going to ask you that same question, but I want to ask you a question. We have spoken about it. So lessons we've learned in healthcare, how does that apply to other industries? And please share the initiatives that we're thinking about launching.
Yeah, so Nick and I and Laird and Dan and multiple others over the last few months have been thinking about where do we take this next? And I've been real passionate, as has the group, about the food and beverage industry is a place I think we'd like to bring together a similar consortium to work on the risks and threats that come from COVID and future pandemics. So I'm really excited that Nick and the team at USC is very supportive of moving forward with that kind of initiative. So I think if we have one slide, maybe we can show that might be teed up. If not, I'm happy to roll without a slide.
Can we bring up the slide, Disha or Suchita, Dennis? If not, do you have, Ron, you can share? All right, just let's roll with it.
I can speak with it. Yeah, no problem. Look, what we plan to do is organize a similar parallel consortium to the healthcare consortium at USC to work on food and beverage and the risk both of COVID as well as future pandemics. So there's a number of different areas that we're interested in: digitization, traceability, food safety, food waste. I'll share with you, we've got a slide built that talks about it. And the purpose of calling it out now is we are looking for folks that might be interested in having input to that. It doesn't necessarily have to be from food and beverage. So I was pleasantly surprised when this team was willing to adopt me into their team, even though I didn't come from healthcare. So I guess what we'll do is we'll share it in the communication on HUVA, the work we're doing, the plan we've got to move forward, and we'd like to kick this off by the first of the year. And I guess my ask of the group is, of those listening, if you're interested in learning more, if you're interested in participating, reach out to Nick or I, and we'll get the ball rolling on the Food and Beverage Consortium out of USC.
Absolutely, Ron, thank you very much. And I think, as you realize, the food supply chain was also disrupted. And the last thing you want to do is disrupt the food supply chain, because if the mom sees that her children are hungry, she will take the baseball bat and start to go out to really look for the answers. So we cannot afford the food disruption in our society. And I think I'm pleased to really work with this team now to take second prong into the food supply chain. Once again, I want to thank you, panel, not only just being here today, but your absolute efforts over the last 7-8 months in driving this consortium, showing the world that we can work together in industry and academia and find incredible solutions by collaborating. So thank you again. Appreciate it. Wink.
Okay, thank you, Nick. Thank you, panelists. Thank you for the great work you're doing. Kind of a somber note to hear where COVID's going to be at our heels for a while. So anyway, thank you again.